Hi, this is Dr. Pedro Ramirez, editor-in-chief of the International Journal of Gynecological Cancer. Today, I have the great pleasure of having back two great friends, Dr. Mary Leitao from the Gynecology Service, Department of Surgery, Memorial Sloan Kettering Cancer Center in New York City, and then Giuseppe Cucinella, formerly at the Mayo Clinic in the Department of Obstetrics and Gynecology at Rochester, Minnesota, but currently at Pascale Institute in Naples, Italy. And we're going to be discussing in this podcast the lead article for October, endometrial carcinosarcoma without myoinvasion. Mario, Giuseppe, great to see you again. Thank you so much for accepting our invitation.
Oh, thank you for having us.
So obviously, lead article, very, very pertinent topic. What do we do about these tumors, carcinosarcomas, that apparently seem very low stage without any myoinvasion? So Mario, I wanted to start by discussing, can you just tell us briefly what are carcinosarcomas, how frequent are they, and what's considered the standard treatment today for early stage disease according to guidelines?
Yeah, thanks, Pedro. So carcinosarcomas, as many of you know, used to be considered sarcomas, which they have not been for a long time. Really felt to be a metaplastic process from a high-grade endometrial carcinoma. So they're treated as a carcinoma, as a high-grade histology, a high-risk histology, if you will. They account for approximately, I guess, about 5% of all uterine cancers that we see. However, they actually have disproportionately account for a higher rate of deaths and bad outcomes because of their high risk. Standard. It depends on which guidelines you're using. Obviously, here in the United States, we're a member of the NCCN. So NCCN is our guidelines here for me. And I know that ESGO just recently came out with their guidelines, which I had to actually pull up because they're somewhat not clear cut. But for at least the NCCN guidelines, for stage 1 carcinosarcoma, which includes non-invasive because that stage is based on the prior FIGO stage. For stage 1A, it actually states that chemotherapy is a standard with vaginal brachytherapy, which can be debated. And then it says plus or minus external beam radiation. For all the other stages, it says also systemic therapy is the primary treatment, and then it's optional radiation of whatever sort you want. So that's the NCCN guidelines. The ESGO guidelines actually classify these. I'm not even sure. I had a hard time figuring out. And I'm getting from that in non-invasive carcinosarcomas, they're actually saying no treatment possibly for them because it's an uncertain risk category from what I could understand. But again, that's not based on any science. And to lump all these cancers together that are of these high-grade histologies, I think is not the best thing to do. So I still feel that the NCCN guidelines are the correct ones in that these patients, by standards, should be treated with chemotherapy, and then the role of radiation and type is debatable. And all the trials in this disease have included all stages, of carcinosarcoma, and they've always only been mostly chemotherapy based, with optional radiation thrown in there. So that's my thought on this disease, is that they should all be treated with chemotherapy as their primary post-op, obviously surgery first, and then with nodal staging, and then post-operatively with a systemic therapy. And then we here at MSK use just vaginal brachy for these cases and rarely use external beam.
Excellent. So thank you for that great introduction. And now, Giuseppe, I'll turn to you for the next few questions. First of all, actually, why did you consider that this was an important study to conduct at this time? Why look at carcinosarcomas without myoinvasion?
Yeah, thank you for the point from this question. Well, when looking at this subset of patients, so patients with tumor linked to the endometrium or to the polyp or with no residual disease in the hysterectomy specimen, we can see that this clinical scenario is extremely rare, and the literature is very scarce in this sense. So the oncological outcomes for this clinical scenario are unknown, because there are only few cases reported in the literature. And also, it seems that when we look at the serious clear cell carcinoma or clear cell carcinoma of the endometrium linked to the without myoinvasion, in this case, post-operative chemo doesn't seem to offer a clear benefit. So we know that assessing the long-term survival outcomes of these patients without myoinvasion with carcinosarcoma will be very important and assess whether post-operative therapy will be part of this outcome is either important as well.
So Giuseppe, when asking this type of question, of course, obviously, multiple institutions need to get involved. So tell us a little bit about methodology and actually what was the inclusion criteria and analysis for the study?
Okay, yeah. Our study, as you said, was a multi-institutional, and we included was a retrospective study. We included 11 centers worldwide. Our cohort of patients were patients with a final diagnosis for uterine carcinosarcoma without myoinvasion. This meant tumor was either confined to ovaries or confined to the endometrium, or had no residual disease in the hysterectomy specimen after preoperative biopsy and endometriosis. All cases were surgical staged, including a hysterectomy, bilateral salpingo-oophorectomy, and nodal surgical staging. And we assessed the oncological outcome for all patients, and then we performed a further analysis stratifying the patient based on the tumor status and whether or not they received adjuvant chemotherapy. So standard analysis were used, such as the Kaplan-Meier estimates and also the long-range testing, while multivariate modeling was not due to the small number of cases.
Yeah, so by all other definitions, very low risk criteria, except that the carcinosarcoma was the criteria of concern in this case. So let's go actually to the results before we start getting into some of the more granular questions on these results. What are some of the things you want to highlight?
Yeah, so first of all, this study highlights the aggressive behavior of carcinosarcoma, even if they are without myoinvasion, because we saw a relatively high recurrence risk of about 30%, with a predilection of distant spread, and talking about the recurrence pathway. Then we found no statistical significant difference in the oncologic outcomes among patients based on tumor location. So no difference if the tumor is in the polyp, in the endometrium, or in the without the residual hysterectomy. And similarly, the difference in oncological outcomes with the use of chemotherapy were not statistically significant. Told, this finding may be limited by all relatively small sample size. In this sense, it's important to note that the recurrence-free survival curves and the overall survival curves were visibly separated in favor of chemo group, with a p-value of 0.08 and 0.07. So great caution is needed to simply state that the chemo offers no benefit, and it very well might when putting all the data in perspective. So now we need to look at overall in sense of this data, not just to look at the p-value as it is.
Yeah, if I could just highlight that importance, this is just this is a perfect example of statistic analysis is one thing, but really you have to look at all the data and look at the curves and make assessments, and not overly rely on a p-value to make pretty strong recommendations that could have significant adverse effects on patients. And when you see the curves, they are obviously separated. There's no, and they're proportional, so they're obviously separated. Clearly, the p-values are quote unquote near significance, which we all know that 0.05 is just an arbitrary cutoff. So I would really be careful to say that because it's not statistically significant, we should no longer that this supports not treating these patients. And I actually, when you look at the entire data, I think it actually supports continuing to treat these patients.
Yeah. Well, great. Thanks, Mary, for adding that information. And I just want to one more question to Giuseppe, and we'll get back to Mario in a second. Questions from our fellows. And Giuseppe, you were one of our former fellows. This one comes from Helena Obermeyer from Sydney, Australia. And she's asking, in your study, features like LVSI, nodal status, peritoneal cytology also played a role in recurrence risk. Are there any combinations of these factors you believe could help us better define truly low versus high-risk patients within this early-stage uterine carcinosarcoma group?
Yeah, thank you, Elena. That's a great point. Well, first of all, our study was limited to node-negative patients, because we wanted to provide a clear analysis of oncological outcomes for this subset of patients. Then, while we observed a high rate of lymphovascular space invasion, because it was about 10%, and also a high rate of positive peritoneal cytology, it was about 12%, then our univariate analysis found no statistical association between these factors and their parents. However, I believe that the combination of these factors, such as LDSI or the peritoneal cytologies, along with more detailed pathological data on the carcinosarcoma, on the histology, on the sarcoma dominance, on the sarcoma type, for sure could help to better define a low-risk patients, a kind of low risk, into this big group of carcinosarcoma patients without myoinvasion.
So now, Mario, I'll turn to you for this one. This one's from Rossano Marina from Milan, Italy. And she's asking, given the long time frame of the study and the evolution of the FIGO staging system, how did you manage FIGO classification at diagnosis to ensure population harmonization?
Yeah, that's a good question. Everyone always brings up the long time periods in these retrospective studies. And in some situations, that is a valid concern. But now that we've been doing this for 20 years, you and I at least, you actually notice that nothing really's changed in 20 years for carcinosarcoma. So the surgery's still the same, except that maybe we do sentinel node mapping only now, which makes no difference. And the therapy's been essentially the same for these cancers, which is always to give some therapy afterwards. And there hasn't been any major changes except for maybe HER2 new and things like that. And immunotherapies for the advanced stage ones and things and as such. But these are low stage cases that would not really be eligible for immunotherapies, and usually we did not give Herceptin in these cases. So I'm not as concerned about the long time frame in this data set, especially with such a rare event, a rare disease. It's the best we can do. As you notice, we don't mention anything about stage at all in that paper. We don't recognize the new FIGO stage, so really, in my mind, is not pertinent to our data. It is clearly based on our aggressive histology type that's not invasive into the uterus, and that's all that matters in this cohort right now.
Okay. So now I'll turn back to Giuseppe. This question comes from Natalia Tejeda in the Hospital Clinic of Barcelona in Spain. And she's asking, given the rarity of endometrial carcinosarcoma without myoinvasion and the resulting challenges in assembling large homogeneous cohorts of patients with this tumor, do you believe your findings are robust enough to support recommending adjuvant treatment for all patients with carcinosarcoma confined to the endometrium?
Well, it's a good point. Well, even though our study included 97 patients and making it one of the largest series on carcinosarcoma without myoinvasion, now we cannot make a definitive conclusion adjuvant treatment, and this is due to the limitation in the statistical analysis without more sample size and also the retrospective nature of the studies. For sure, based on the visual and proportional separation of the Kaplan-Meier curves in favor of chemo, with a p-value, as we say, 0.08 and 0.07, we just can say now that there is no statistical difference. But as we said before, this is an example of how the overall assessment can help to understand better the data and not just the p-value. So for sure, the data and the separation of the curves would suggest that post-operative chemo should be given to this cohort of patients with such high risk of recurrence. But for sure, higher level data to provide greater support or recommendation for the treatment are lacking and will be needed. And however, it will be very challenging to conduct a rigorous prospective studies in such a rare cohort of patients, and possibly others could also report their outcomes with a larger numbers. So these are the main point to highlight.
Okay. So thank you for that. And Mary, I'll turn back to you. Let's talk about imaging and surgery. Rim Abu Chakra from Lebanon. She's asking, does preoperative MRI or PET-CT scans provide any useful information for surgical planning for these early stage high-risk tumors? Also, should peritoneal washings be a mandatory of surgical staging for all carcinosarcomas, given its potential prognosis implications?
Yeah, that's a great question. I think in terms of imaging, because these are when you have a biopsy, just carcinosarcoma, these are high risk cases for metastasis. So at least a CT scan should be done of the chest, abdomen, pelvis. That's been our practice here. MRI really won't change what we do, um, you know, whatsoever in this case. The surgical approach is going to be the same if it's uterine confined. And then a PET, I am not a fan of PET scans at all. There's a high false positive rate with it. I think people make decisions based on PET scans incorrectly many times. So I know people do it. I don't. I don't. And again, it depends on the quality of your CAT scanning at your institution, of course. So I wouldn't. I don't routinely do MRI for these cases, nor do I think it's useful, unless there's concern of like local extension into the bladder or rectum. It might be a good way to assess local extension, which is relatively rare and obvious usually on exam. But I do think some form of metastatic evaluation prior to surgery is necessary, and that could be with the CT scan plus or minus the PET. The other point was, what was the other question?
Washings.
Oh, washings. Yeah, with the whole washing things we keep going back and forth about, and the old FIGO, the prior FIGO staging eliminated from the staging system. We still do washings for all our cases, endometrial cancers in general. We feel that in some situations it might be of value. We recently looked at our serous carcinomas and those who had limited to endometrium disease like these, but had negative washings. The chemo didn't seem to help those cases, where with the positive washings, it seems like it might have. So we still do it. It is highly debatable. Um, One could even argue why even take lymph nodes out if they're all getting treated with chemo anyhow. So that's definitely a valid question too. Is it really valuable to take out lymph nodes? And then we are about to hopefully submit to you guys again. We've recently looked at all these high-grade histologies and the utility of detecting microscopic disease in the omentum and peritoneal biopsies, and it's like 0.5%. I mean, it's exceedingly low. And the ones that had microscopic disease in those biopsies all had sentinel node positive situations. So one could even argue, why do any washings or even peritoneal or mental biopsies in this disease? And one could even extend that to say, why even take nodes out? But with sentinel node mapping being relatively low morbidity, it does provide at least some staging information and prognostic information, because node positive disease is a higher risk than node negative disease likely.
Great. Thanks for providing the insight into that upcoming paper. That sounds like a really good manuscript that we look forward to receiving. So now next, another question from Rosano Marina. I know a favorite topic of yours. She's asking, does our current staging and risk classification system adequately capture the dual behavior of carcinosarcoma with both lymphatic from the carcinomatous component and hematogenous from the sarcomatous one, especially in cases without invasion?
Yeah, I don't know how to answer that question. As we don't want to. We've talked about the current FIGO stage, and we're not endorsing it, so I haven't really put much thought into that. Again, staging should be anatomic, and then you can have risk classifiers using stage as a basis. But so I think that, and there's a lot of issues with the staging system, and that is one of them, is that it's not anatomic, and then it lumps all these cases into a certain stage with very limited data specific to carcinosarcoma. So I think that's the limitation of current staging. So we still use the prior staging system, which was more anatomic, and that's all that we need to do. Of the pattern of spread, of course, that really still doesn't change how a staging system should be. I mean, it either spreads or it doesn't. And often, though, with carcinosarcomas, you see the carcinomatous part is what's metastasizing for some reason, and not the sarcomatous part. Although that can happen, but to a much lower degree. So usually when you have metastases, you'll find out that those are usually mostly the carcinomatous element of the carcinosarcoma. So yeah, no, I don't think well, besides the other issues with current staging, I'm not sure that the pattern of spread should impact how you stage these cases.
Okay. So we'll turn to Giuseppe for the next couple questions. Giuseppe, in your study, you have demonstrated the poor prognosis of patients with uterine carcinosarcoma without myoinvasion. Have you hypothesized the existence of specific molecular features that might underlie the aggressiveness of these tumors? And do you plan to perform comprehensive molecular profiling to investigate this possibility?
Well, thanks. These are a great question. Well, in our study, we didn't look at the molecular features of our core. However, it's well known that the majority of endometrial carcinomas, and it's about more than 70-75% of these, share molecular and genomic similarities with high-grade serous ovarian cancer or serous endometrial carcinoma, such as the PD3 mutation. And moreover, we need to consider that, as we said, the endometrial carcinoma is not just a single entity, but encompasses different histologies, subtypes, and so it depends on the carcinoma elements, on the sarcoma elements, depend also on the dominance pattern, if there is a dominance of the sarcoma patterns or not. So while we are currently not planning the comprehensive molecular profiling study, for sure we believe that further research is warranted in this sense, and not just the molecular classification, but all the genomic study of this tumor.
And as a follow-up to that, Giuseppe, another question from Helena Obermeyer. She's asking, do you see a role for molecular markers or genomic features in guiding therapy and identifying who might benefit from targeted therapy?
Well, and given that endometrial carcinoma was historically classified as a sarcoma, it was often excluded from clinical trials of endometrial cancer. So now constantly there is a lack of definitive data on the efficacy of target therapy in this type of disease. Looking ahead, for sure, I believe that genomic analysis will be crucial for guiding therapy, and research is needed to identify the specific actionable mutations and maybe the pathways that could help stratify this high-risk population and maybe identify the novel target therapy, identify the best candidates for this new target therapy.
Great. So now, Mario, turning back to you for, again, the topic of surgery, Sofia Bigardi from Italy. She's asking, given that your study spans a long time period and multiple centers, do you have any specific information on the surgical techniques adopted to, as an example, minimize peritoneal dissemination? How do you think the type of surgery performed might have influenced your recurrence and survival outcomes?
Yeah, let me just maybe Giuseppe can chime in here too. I forget what the breakdown was of open versus laparoscopy or MIS. But I'm sure we have both approaches there. We didn't see a difference between MIS or open. So, obviously in MIS, here at least, everyone does it differently. For all of our uterine cancers, we routinely use a manipulator. We don't routinely seal the tubes. And I know those are things that are out there people talk about. We have looked at our data in our high-risk cases. Between MIS and open, we also see no difference in outcomes. So we don't have any MIS with and without manipulator or with or without tubal occlusion to make that comparison. But when we kind of extrapolate by saying, well, if the outcome's the same for open and MIS, and we use almost always a manipulator and don't occlude the tubes, then that probably doesn't make a difference. Because with open, we don't occlude the tubes and we don't use a manipulator. We also don't use but we don't use a manipulator for open surgery. So as best as we can tell from published data, from our data, it doesn't seem to make a difference to do MIS versus open as a start. And it also doesn't seem to make a difference if you use a manipulator or occlude the tubes. And there has been studies looking at uterine manipulators versus not. There was the Rouhani trial, which showed that there was no difference, but that was a small randomized trial, and the results are a little debatable because of the number of cases there. But I always say, these patients are often diagnosed with hysteroscopy, D&C, and often multiple, yet, to have a manipulator, and no one cares about that and thinks that that's a problem, forcing fluid in there into a tumor environment. And forcing it out the tubes, but to use a manipulator for, you know, if you do this often, it's about 30 minutes that you're actually manipulating the uterus as you do a hysterectomy. But that seems to be a problem. I don't know how I can, you know, put those two things together in my mind, that pre-op hysteroscopy with fluid and DNCs is no issue, but a manipulator during surgery is, I don't know.
Yeah. And now, as a follow-up to that, also a question on the time frame of the study. Natalia Tejeda, she's asking, given the evolving protocols in chemotherapy and radiotherapy during the time of your study, did you collect information on variability in treatment modalities? Would you expect differences in outcomes in a more recent cohort treated according to current protocols of adjuvant treatment?
Was that for me, Pedro?
Yeah.
Oh, so yeah, you know, again, as I said earlier, I don't know that treatment protocols for this particular cohort has changed over the years. I mean, we do. I mean, the only thing, the major changes have obviously been. I mean, chemo's always been platinum based essentially. I mean, or IFOS Taxol in the past prior to carbotaxol, but and then the randomized trial in the U.S. showed there's no difference between carbotaxol, IFOS Taxol, just toxicity profile. So really, the systemic therapy hasn't really changed. The only differences for carcinosarcoma now is, and for endometrial cancer in general, is, you know, obviously checking for HER2/neu, which carcinosarcomas can probably 30% could be overexpressing or high levels of HER2/neu, and also immunotherapies. But neither one of those are actually considered for stage one, you know, old FIGO stage one carcinosarcomas or cancers anyhow. So we aren't giving immunotherapies for any stage one case right now, regardless of MMR status, in the post-op setting. And we're also not routinely giving trastuzumab for our stage one HER2 expressing cases. At least that's not, data is not out there to support that. I mean, it's for higher stage cases, is my understanding. So I don't, and then the radiation has been a debate for since we were all fellows, you and I, you know, the whole role of radiation in these cancers is also a thing of debate. You know, radiation therapy and all the trials, whatever trial you look at, whatever risk case, all it's ever impacted is local control. It has no impact on PFS or OS in any study you look at for any risk group. And so then the debate comes, how important is quote unquote local control? And then in a disease where the metastasis rate is really extra pelvic in a great proportion, why we focused on local control, we really should just be focusing on systemic therapy and reserve that radiation for when it might be needed in the future. So again, I don't think that treatments have really changed much for a stage one carcinosarcoma over the last 20 years. And it's basically chemotherapy is the most important part of treatment. And then the radiation, the debate continues and never really has stopped. And I know every person, if anyone listening to this is going to have their strong opinions one way or the other on the use and type of radiation for this disease.
Yeah. So next question is for Giuseppe, but this is from Rim Abu Chakra. And it's kind of like a follow-up question, and I think Mario pretty much covered it. But any thoughts, Giuseppe? She's asking, our approach and focus, should it be more on systemic therapy, given that most recurrences are distant rather than local?
Yes, I mean, it's a kind of continuing answer. So the point is, our study has a limitation, so retrospective nature, very small sample size, so we cannot now have a definitive recommendation. And also we cannot have a definitive recommendation or a definitive shift away from vaginal brachytherapy. However, as we said, the poor outcomes and also the distant pattern of recurrence warrant the consideration of systemic adjuvant treatment. And it's also something that the NCCN guidelines already recommend. So they recommend systemic adjuvant treatment for all patients with carcinosarcoma stage 1, regardless of myoinvasion invasion. So the decision for the systemic therapy should therefore be realized based on several factors. But I mean, it seems that post-operative chemotherapy is the most critical therapy to consider, and vaginal brachytherapy at best will provide only vaginal control, and as we say, the value is the backbone and also not problem in this sort of patient. And finally, it's important to know that randomized controlled trial in carcinosarcoma of all stages by GOG did not mandate the use of any radiotherapy and were only chemo based trial. So all this information maybe are looking for like more chemo treatment for sure when the radiotherapy and vaginal as well are for more for the local control, as we say.
Okay, so on that topic, I'll go back to Mario. This question is from Mariana Carvalho, and she's asking, according to NCCN, the addition of external beam radiation to chemotherapy and vaginal brachytherapy is optional. How do you decide to add external beam radiotherapy in your clinical practice?
Yeah, for carcinosarcoma, we almost never use external beam. I'm speaking from an MSK sort of group approach. Of course, there's always debate and there's always individualization here and there, but the overall consensus here for carcinosarcoma is that they get postoperative carboplatin and paclitaxel and vaginal brachytherapy. That's been our kind of approach for carcinosarcomas of any confined to the of any stage essentially. External beam radiotherapy, we don't really use it much for this disease, so there really isn't any factor that we would consider, except for maybe locally advanced disease, maybe, where you do a chemoradiation approach possibly for better local control, especially if they're symptomatic with bleeding and pain and things like that. So, obviously doesn't apply to this cohort. And for stage 1, 2, and 3, and 4B, I guess, not 4A, it's basically chemo with the vaginal brachy. And we wouldn't do vaginal brachy for someone who's got advanced carcinosarcoma where we're not operating. That's a whole different discussion there. And now you would add immunotherapy to those cases. So that's where and you would do HER2 status and you would add Herceptin potentially. And so that gets altered there. And when you have obviously metastatic disease, they're used to radiation therapies. I don't see a role for it in that situation. And again, back to this specific cohort, it really, we never consider external beam for this cohort, and it's just chemo and IVRT. And we don't consider it for node positive disease either. And carcinosarcoma is at our place. We just do chemo, and we will give them vaginal brachy too.
Yeah. So then you mentioned immunotherapy. I'll turn to Giuseppe. And this question is from Filippo Capomacchia from Italy. And he's asking, given that adjuvant chemotherapy did not confer a statistically significant survival benefit in your cohort, what potential role might targeted therapies or immunotherapies play in these patients? What should be the next steps in developing personalized treatment strategies for this rare type of tumor?
Well, good questions. And the point is, the lack of statistical significant benefit from adjuvant chemotherapy in our study is almost centrally due to our small sample size and with respect to nature. So it's possible that a larger study could reveal a benefit in the use of chemo. While regarding the immunotherapy, first of all, it's important to point out that the most major practice-changing trial, such as the Keynote 775, the Garnet trial, or the Tango trial, the NRGGY0188, did not include patients with endometrial carcinoma. So this makes it difficult to apply those results to the various type of carcinosarcoma. And also they were not stage 1 patients, as we know. So yes, I believe that target therapy holds significant promise, and several agents, including immunotherapy plus tyrosine kinase inhibitors, are currently under investigation. There are dedicated clinical trials, and also, as we say, HER2 target agents also are promising for the future. But for sure, we need to wait for this ongoing trial and then understand if we can also give immunotherapy for stage 1 carcinosarcoma or not.
Okay. So as a last question, and I'd love to hear to you both is, what do you do in your practice today? So I'll start with Giuseppe. In a setting where a patient comes in with a pathologic diagnosis of no residual tumor in that hysterectomy specimen, or just limited to the endometrium or to a polyp, what's your recommendation for that patient?
Well, this is a tricky question because let's see. For sure, I will discuss this patient into a tumor board, so with a multidisciplinary discussion, and I will consider different factors: the performance status of the patients, the age of the patients, the lymphovascular space invasion, the carcinoma elements if they are low grade or high grade, the sarcoma elements if they will be heterologous or homologous, and the dominance, and also the molecular profile. As we said before, even the ESGO 2025 guidelines classify this patient as a medium uncertain risk. If we consider all these, maybe there is a dominance pattern of sarcoma pattern, or there is a p53 mutation analysis, or there is an high grade of the sarcoma element, I would suggest I will go for, at least canceling the patient for chemotherapy. And so discuss with the patient the potential role, even if we need to be honest with the patient, say that there are very low level of data on support of this, at least in this subset of patients.
Great. Mario, what do they do at MSK?
Yeah, I mentioned it already. I mean, we don't, we don't discuss all of our cases at a tumor board, and we don't discuss these cases at our stage 1 because we have sort of our own internal guidelines that we use based on our interpretation of the data. So these are the treatment for these cases is considered pretty routine now for us. So cases like these, we just give them chemotherapy and vaginal brachy, and we do not discuss every case at our tumor board. It's just it would be impossible for us to do that. We'd have 4 days of tumor boarding if that were the case. So yes, I understand that multidisciplinary tumor boards are important, and we do have it, but we reserve that for really complex situations. And so here, these cases are kind of a routine approach right now. And of course, if you have any trials, and any trial, we always obviously do lots of trials. So if we have a trial available for these patients, we would. We have our own next-gen sequencing platform called MSK Impact. And so every single one of our uterine cancers of all types get genomic sequencing and classified, and also genetic testing for germline mutation. So that's what we do with our uterine cancers in general, including carcinosarcs, and then carcinosarcomas. We just give them chemo and vaginal brachy, and we don't discuss them all at our tumor board.
Great. Well, thank you both so much again for accepting the invitation. Thanks for submitting this study to the journal. Very, very important, very interesting data. And again, we really always enjoy speaking with you. Mario, enjoy your time at the Jersey Shore. And Giuseppe, thank you once again. It's great to see you.
Thank you.
Thank you so much.
Always good to see you, Pedro, too.
All right.
Thank you.